Hey, all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out our Top 200 Study Guide. It's a free 31-page PDF. Simply an email will get you access to that. So definitely go take advantage of that. Absolute no-brainer. You can do that at reallifepharmacology.com. In addition to that, definitely go support the sponsor, meded101.com/store. Tons of links to tons of different resources, books, study materials for all sorts of different healthcare professionals. So go check that out at meded101.com/store. All right, the drug of the day today is Revefenacin. Brand name of this medication is Yupelri. Revefenacin is a long-acting muscarinic antagonist. You'll often hear this classification as LAMA therapy, LAMA. And this medication, being a long-acting muscarinic antagonist, can be used for COPD, chronic obstructive pulmonary disease. And that is, obviously where it's used at and its primary indication, FDA-approved indication. So what's unique about this medication compared to some of the other medications for COPD? So tiotropium is a great example of another one within that class of inhaled anticholinergics. This one actually is available as a nebulized formulation. So that's a little bit different than some of the other long-acting anticholinergic or long-acting antimuscarinic agents that you see out on the market. So more specifics on the mechanism of action. So it basically opens up the airways. It's what's called it causes bronchodilation. And it does this by inhibiting muscarinic 3 receptors or M3 receptors in the airway smooth muscle. So this leads to that bronchodilation, basically the opening up of those airways. We get reduced airway resistance, and obviously this can help our patients breathe better who are struggling with COPD. It is dosed once daily, so that is a good thing. I mentioned it is a nebulized formulation. So, in clinical practice, obviously that can be challenging to be tied to a nebulizer once a day. So obviously this might not be the right medication for some patients, but for patients who have trouble with coordinating movements with, a dry powder inhaler or a metered dose inhaler, a nebulized formulation might help ensure that patient gets that medication more effectively, where they can sit and they can breathe in the medication over time. So, it kind of fills a little niche there. If you've got a patient that has been struggling with COPD, we think they're at least trying to take their medication regularly. We believe they're being adherent, but maybe they don't have enough inspiratory force to get some of those other medications, whether it be a dry powder inhaler or something else. Maybe we don't feel like they can adequately get that medication into their lungs to help them breathe a little bit better. And in that case, maybe a nebulized formulation like this might be playing a role in that type of situation. In the realm of COPD treatment, like where does this medication fall? So typically, when patients are in that mild type of stage, mild COPD, we're going to often start with just kind of a short-acting bronchodilator, beta agonist, or inhaled anticholinergic. But as we get to further stages where we need a controller medication, LAMA therapy or LABA therapy, long-acting beta agonists, are generally considered first line. So Revefenacin certainly could play a role in that kind of first line controller therapy if something is needed in COPD. That dosage, administration, standard dose, 175 micrograms once daily, again via nebulization. So again, that can be a challenge. You have to be tied to a nebulizer once a day. You got to make sure that patient is getting that dose. But it is convenient for those that cannot effectively navigate how to use a meter dose inhaler or a dry powder inhaler as well. Very, very important note. This is a good patient education piece. It is not meant for acute relief of symptoms. Okay, so really, really important thing to note. That onset of action isn't quick enough to be a great acute symptom relief agent. Okay, so really want to hammer that home to patients, making sure that they're not using this kind of on an as-needed basis and expecting themselves to breathe a lot better immediately if they start getting their nebulized dose. All right, let's shift a little bit to adverse effects. Usually upper respiratory things are what you're going to see with this medication. You might get some irritation that causes a cough, some nasopharyngitis, possibility of increasing the risk for an upper respiratory tract infection. And then, of course, it is an anticholinergic type medication. Now, the systemic absorption isn't probably that significant. However, when we maybe use it with their anticholinergic medications, we could have some potential additive effects. And I'll talk more about some of those other medications in the drug interaction section. But with anticholinergic activity certainly comes, urinary retention, constipation, visual challenges, even rare cases of contributing to CNS type adverse effects like confusion, for example. So again, this is certainly possible. It's not crazy likely just because we don't get a ton of systemic absorption typically with respiratory medications. But yeah, these are likely and something that, not are likely, but they can happen, and it is definitely something that you should be aware of. In clinical practice, what do I see the most? I would say dry mouth is by far what I see the most when we use long-acting antimuscarinic agents like this. So if your patients complain about that, just know that that's not really a surprise and definitely can happen to some patients for sure. Warnings, precaution. We've always got that warning on narrow angle glaucoma as well as BPH. It can kind of worsen that obstruction potentially that's caused by BPH. And again, that's both those are due to the anticholinergic activity of the medication. And then that CNS type effects. Again, I'm not typically crazy worried about it with revefenacin, an inhaled anticholinergic. But, you may see some confusion and dizziness and things of that nature in rare cases. So I wanted to cover a couple of the most common prescribing cascade examples that I've come across. So pay attention to saliva substitutes or medications that kind of stimulate the production of saliva. Again, that's that anticholinergic adverse effect, and we want to try to avoid that prescribing cascade if we can. Constipation can happen with inhaled anticholinergics, not, again, crazy frequent, but certainly keep an eye on laxatives after the initiation of revefenacin, treating that adverse effect of constipation. And then urinary retention, if you see an escalation in alpha blocker therapy or 5-alpha reductase inhibitor therapy, that's a good sign that patient's having worsening urinary retention issues, and certainly Yupelri could be contributing to that. Pharmacokinetic standpoint, a couple important highlights. So the half-life certainly does support once daily dosing, so that duration of action is acceptable to give this medication on a once daily basis. And then that systemic exposure, the absorption of this drug into the bloodstream is relatively low, which obviously helps reduce the risk for those systemic anticholinergic effects. What are we going to monitor? So obviously we're looking out for COPD exacerbation frequency, We can look at FEV1, peak flow, those type of things. And then we're going to look out for some of those adverse effects as well. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, NAPLEX, ambulatory care, geriatrics, or BCMTMS, go check out meded101.com/store. We've helped thousands of pharmacists and students prepare and pass their exam, and we can absolutely help you too. All those links, all those study materials, you can go find meded101.com/store. All right, wrapping up with drug interactions. First and foremost, I'll be totally frank with you and say I don't worry a ton about drug interactions when it comes to Revefenacin and the inhaled nature of the medication use, and obviously the low general systemic absorption as well. So it's not crazy high on my list, but obviously first and foremost, you got to think about that anticholinergic burden. So tricyclic antidepressants like amitriptyline, nortriptyline, antihistamine like diphenhydramine, hydroxyzine, antipsychotics have anticholinergic activity as well. Olanzapine, quetiapine, good examples there of medications that can have some anticholinergic activity. Other bladder antimuscarinics like oxybutynin, solifenacin, these can all compound, increase the risk for anticholinergic adverse effects. Dry eyes, dry mouth, urinary retention, constipation, increase the risk of central nervous system confusion. So again, plenty of additive type medications that may increase the risk to see some of those systemic effects from Revefenacin with adding on top of it. And then we've also got some other centrally acting anticholinergics like benztropine, trihexyphenidyl, scopolamine. Those are all medications that can be used in Parkinson's disease. So I've seen benztropine used for that. Trihexyphenidyl, again, not used very often due to their highly anticholinergic activity, but I have seen them used occasionally as well. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor if you enjoyed this episode, enjoy the podcast in general, go leave a rating review on iTunes, Spotify, whatever platform you're listening to. I greatly appreciate that. Obviously, go check out the free Top 200 Study Guide, 31-page PDF. You can do that at reallifepharmacology.com. And if you got any comments, suggestions, feel free to reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care and have a great rest of your day.